Uh, Good evening. Thank you, Endocrine Society of India and International Society of Endocrinology for giving us this honor to deliver this talk on endocrine arthropathy. A very good evening to the respected chairpersons and to all present here. And also thank you, Dr. Devarati, for that excellent presentation. And yes, happy Valentine's Day to everyone. So my topic is endocrine arthropathy. So arthropathy is a disease of the joints, as we know, and joints are complex structures composed of bones, muscles, synovium, cartilage, and ligaments. Endocrine arthropathies are diseases of the joints related to disturbance in the metabolic and endocrine functions. So we now know that there is a two-way traffic between the musculoskeletal system and the endocrine system because when the endocrine system affects the musculoskeletal health via its actions on the formation, differentiation, and maturation of cartilage, bones, and muscles, and indirectly through the modulations of elements and environment necessary for good musculoskeletal health. In other words, the body's handling of macronutrients and micronutrients like calcium, phosphate, and other molecules, and also providing a normal pH. We also know the musculoskeletal system is now an endocrine system via the release of secretomes with myriad functions that can range anywhere from modulation of the energy homeostasis of the body to reproductive function. So as has been mentioned earlier by the chairperson, endocrine diseases and arthropathy are closely linked. So it could be that certain diseases of the endocrine glands are associated with arthropathy, or certain metabolic disorders. A lot of the questions we got it in the quiz could be also associated with arthropathies. And again, there could be an association. For example, an autoimmune process could lead to a rheumatoid arthritis as well as to, let's say, Graves' disease, or the effect of treatment of one on the other. So let's say somebody with rheumatoid arthritis has been offered glucocorticoids. This could result in Cushing's syndrome. So, but whatever it is, what I'm going to discuss is on the endocrine disorders and metabolic disorders, and I shall not discuss the association today. So coming to the acromegalic arthropathy, we know acromegali is a condition that is characterized by growth hormone excess and its principal mediator, that is the insulin-like growth factor 1. The prevalence of arthropathy is around 30 to 70% or greater, and this may increase with age. It could be a presenting symptom, or the presentation may be delayed by approximately 10 years after disease onset. The articular manifestations are due to the involvement of the articular structures and the entisopathy, that is the ligamentous or the tendinous insertion to the bones. The arthropathy occurs in stages, and therefore the earlier stages may be partially reversible. So if you look at the pathogenesis, because of the growth hormone excess, there is IGF-1 excess, systemic as well as local. And along with it, there is increased proteoglycan synthesis, glycosaminoglycan synthesis, and cell replication. So in the early phases, there is articular widening, soft tissue hypertrophy, and hypermobility of the joint. In the later stages, there could be cartilage ulcers, subchondral cysts, articular thickening, and others. And in the later stages, there are features of degenerative osteoarthritis, which may be non-differentiable from the primary osteoarthritis. The typical characteristics of an acromegalic arthropathy is characterized by polyarticular joint pain, which is swollen and tight, and crepitus and effusions are present, but it is typically non-inflammatory in the sense that there is no fever, there is no warmth. It affects the large joints more than the small, and the joints that are typically affected are the spinal. In the peripheral, the knee is commonly involved, but many other joints, including the joints of the hands and feet, can be involved. And also there could be involvement of the temporal mandibular joint. It may be associated with compressive features like the carpal tunnel syndrome. So here we see that there is a thickening of the soft tissue along with the enlarged exaggeration of the bony tufts of the distal phalanx. Similarly, here also there is enlargement of the distal tufts, and there is an increase in the metacarpophalangeal space, but there is a decrease in the interphalangeal spaces. So telling us that these are different stages of acromegalic arthropathy in the same joint. There is enlargement of the distal end of the radius as well as the ulna, and we can see periarticular calcification. So this is the typical joint finding. If we try to differentiate it from the primary osteoarthritis, we see that in primary osteoarthritis, there is a decreased reduction in the bones joint space, whereas in acromegaly, there is an enlargement of joint space initially in the earlier stage. And here we can see the entisopathy, where there is calcific deposit in the tendinous insertion of the Achilles tendon to the calcaneum. So what is the prognosis? In early stages, it may be reversible on normalization of the growth hormone and IGF-1. Certain studies have shown that offering surgical treatment of acromegaly in these patients improves the outcome rather than the medical treatment, but then it is not a unanimous finding. In the advanced stages, the arthropathy is irreversible and progressive because the disease pathogenesis has already been started and accelerated despite the normalization of growth hormone and IGF-1. And in such conditions, we need to provide symptomatic treatment like pain relief, physiotherapy, and maybe in the quiescent stage of the disease, joint replacement. Therefore, early diagnosis and adequate management may improve or at least may contribute to the reversibility of acromegalic arthropathy. So when to suspect acromegalic arthropathy? When somebody with acromegaly has joint symptoms. But more importantly, in somebody who is too young to have an osteoarthritis, but develops symptoms of osteoarthritis. For example, a 25-year-old gentleman having osteoarthritis of the knee, and there could be telltale signs of acromegaly in the form of, let's say, prognathism or metroglosia or enlargement of the hands and feet. Now coming to the musculoskeletal complications of diabetes, there are lots of it. I shall discuss on the areas which focuses on the joints. So there could be adhesive capsulitis, calcific tendinitis, diabetic cheiroarthropathy, Charcot's neuro-osteoarthropathy, and diffuse idiopathic skeletal hyperhormesis. So frozen shoulder is an adhesive capsulitis, runs into 3 stages. There is a painful freezing phase, the adhesive phase, and the recovery phase. Frozen shoulder is typically unilateral. In diabetes, also unilateral, but it can often be bilateral in diabetes. The pathologic features are characterized by the thickening of the capsule and synovium with contracted joint volume, and there is a chronic inflammatory infiltrate with dense collagen deposition and fibroblasts. So if you look at an X-ray, it would be normal. More often than not, the X-ray is done to rule out other causes. I remember one case where the patient had thought it was a frozen shoulder, but on doing the X-ray, it was actually a metastasis from a lung cancer to the humeral head. MRI, it's a clinical diagnosis. MRI USG may not always be necessary, but if done, there would be thickening of the joint capsule and the ligaments around the shoulder joint. And the USG, on dynamic imaging, there would be limitations in the sliding movement of the supraspinatus tendon below the acromion during abduction. So treatment in diabetes is more challenging. It is according to the stage of disease. So in the painful phase, we provide pain relief, whereas in the adhesive phase, we provide physiotherapy. If there's too much of fibrosis, we may have to do manipulation under anesthesia or arthroscopic release. Other joint findings in diabetes includes the calcific shoulder tendinitis, where there is a deposition of the calcium hydroxyapatite crystals predominantly in the rotator cuff. Diabetic cheiroarthropathy is typically exactly not an arthropathy, rather it is a fibrosing condition of the periarticular tissues of the skin and the subcutaneous tissue. And this results in the tightening of the hand and also the contractures of the different joints in the hand, like the MP joint and the interphalangeal joints. And this is a prior sign where we can see there is a lack of apposition of the plantar surfaces of the hand because of the contractures of the joint. And diffuse DISH, or the diffuse idiopathic skeletal hyperostosis, is seen in patients with metabolic conditions like the diabetes, where there is a calcification of the anterior longitudinal ligament. Another very important chapter in the joint affection in diabetes is the Charcot's neuro-osteoarthropathy, which is a very, very huge topic, and I'm just going to touch on it. So it's a destructive arthropathy, most commonly affecting patients with diabetes, can affect others also in the presence of severe peripheral neuropathy. So the pathogenesis is a combination of factor where there is neuropathy, so let's say, and also minor trauma and other metabolic factors. So the presence of neuropathy and therefore the lack of proprioception results in the laxity of the ligament and the hypermobility of the joint, increasing the chances of a trauma. The presence of sensory neuropathy actually prevents the appreciation of this trauma, and therefore the patient continues to walk on the limb that has been subjected to trauma. And the presence of the motor neuropathy also increases the deformity of the foot, increasing the abnormal pressure points. Now, the presence of the autonomic neuropathy increases the vascular AV anastomosis. This results in a warm foot, but at the same time, this also decreases the blood supply to the skin and the bones. So repeated minor trauma along with metabolic abnormalities results in a heightened inflammation where there is involvement of cytokines like interleukin-6, tumor necrosis factor, alpha, and also the rank and ligand system, resulting in the development of Charcot's neuropathy. So whatever the initiating event is, there is an initial resorptive phase followed by a hypertrophic repair phase. So the clinical features are the sudden onset of unilateral warmth, redness, and edema over the foot or ankle after a minor trauma, or if in fact the patient may not recollect a trauma. Or it could be slowly progressing arthropathy with insidious swelling over months or years and occasionally recurrent acute attacks. Painless, but sometimes it can be painful, especially when there is an associated infection. And there is a collapse of the arches of the foot resulting in abnormal bony prominences and foot deformities with pressure ulceration and ulceration. So there are many ways of classification of Charcot's neuro-osteoarthropathy. The quiz master had given one, and there is another classification here. Again, I shall not go into the details of this, but this is how a Charcot's foot looked like, where the foot looks unstable, deformed, and also there is a prominence on the lateral part of the ankle. And if you see there is a fragmentation of the bone with extensive joint destruction, and there is a medial movement of the whole foot, resulting in this prominence. Another X-ray of Charcot's where there is extensive destruction of the metatarsophalangeal joints, where we see there is a bony destruction, along with there is a pencil-like tapering of the metatarsal shafts, resembling a subcandy appearance. So, and this is a graphic representation next to it. Then the rocker bottom foot, because of the collapse of the medial arch, which is replaced by a bony prominence. So diagnosis is based on the symptoms I just discussed. We need to do complete hemogram to look for infection and others, and also relevant biochemistry. In the stage 0, the X-ray may be absolutely normal, but then there would be changes in the MRI. In the later stages, we do the MRI to look for involvement of the soft tissues and other tissues, and also look for others like infections, tendon tears, and osteomyelitis, etc. So the treatment is a multidisciplinary approach where we have avoidance of weight bearing and offloading in acute stages. And if there is infection, we should treat it. Because there is a participation of the rank and the rank ligand network in this, there has been a favorable response to bisphosphonates and sometimes calcitonin in patients who have been offered this treatment in the acute Charcot's. Once the acute phase is over, then gradual weight bearing with prescription footwear can be advised. And if any surgical treatment has to be undertaken, it should be done only in the quiescent phase. Now coming to thyroid function, dysfunction, and arthropathy. Yes, Graves' disease can be associated with arthropathy known as the thyroid acropathy. Sometimes it is also associated with frozen shoulder. Hypothyroidism in adults typically may present with joint arthropathy or joint pain, or stiffness of the joints of the hands and knees, and the joint feels gelatinous. If an aspiration of the joint is done for any reason, then it would be non-inflammatory and there would be high levels of high hyaluronic acid. The good thing about arthropathy and hypothyroidism is reversible on treatment in the adult hypothyroidism. But in the children and in the intrauterine life, there are certain changes which I shall discuss. So this is the thyroid acropathy, where we can see there is clubbing, there is subperiosteal bone formation along the lateral aspect of the phalanx. Also, there is subperiosteal bone formation in the metacarpal bones. So this is the least common extrathyroidal manifestation, which is specific of Graves' disease. Even after the improvement of Graves' disease with the treatment, this problem may persist. Why it occurs is not very well known, but probably there is a role of the TSH receptor antibody and the insulin-like growth factor. So there are numerous skeletal manifestations of hypothyroidism. I shall discuss the area around which affects around the joint, specifically the epiphyseal centers. So again, this was there in the quiz. So in somebody who has the congenital hypothyroidism, there is a mottled appearance of the epiphysis, irregular mottled appearance, and then they can coalesce to form a fragmented or a spongiform appearance, which is known as a stipple epiphysis. Whereas if the hypothyroidism occurs in the childhood years, there could be delayed appearance of the secondary epiphyseal centers, along with the heterogeneous epiphysis and irregular ossification, as we can see here. But the typical stipple epiphysis is found only in congenital hypothyroidism. Now, hyperparathyroidism has a lot of bone manifestations, typically so in the classical one, where it is advanced and where there are late diagnoses. So the bone changes includes osteopenia, subperiosteal bone resorption, and others. But the effects on the joints could be arthritis of the small joints of the hand. It may be associated with pseudo-gout or the chronic calcium pyrophosphate deposition disease. There could be gout, there could be sacroiliitis, and there could be bowing of the shoulders, kyphosis, and other deformities. So this is a rugged jersey spine, which is seen not only in primary hyperparathyroidism, but also can be seen in tertiary hyperparathyroidism, where the increased remodeling of the bone results in the formation of osteoid, which are deposited, which are quite opaque. They may not be calcified, but they are opaque. And so there are alternating areas of sclerosis and translucency, as we can see here, like the jersey of a rugby player, and therefore is known as the rugged jersey spine. And this is the typical appearance of the severe primary hyperparathyroidism. Rather than the joint involvement, there is more involvement of the bones. Now, glucocorticoid effects is very important. We are aware of the osteoporosis that occurs out of glucocorticoids. Today, I'm going to discuss osteonecrosis, which means the death of the bone. And this is the most common non-traumatic cause of osteonecrosis and the glucocorticoids. And the sites involved are the femoral head, and the next is the humeral head and others. This is because of the blood supply of the femoral head is precarious. At the same time, the femoral head has the responsibility of bearing the body weight. And because of these two reasons, if we see the retinacular arteries, which mostly arises from the lateral circumflex artery, supplies around 80% of the femoral head. And such an anatomic distribution of the vascular supply, along with the load that the femur has to take, can increase their proneness to avascular necrosis or osteonecrosis. But it is a result of a combination of genetic, metabolic, and vascular risk. So according to the ARCO task force, which is again a quiz question, glucocorticoid and induced osteonecrosis is diagnosed if all the following are present. There is history of steroid use equivalent to more than 2 grams of prednisolone in a 3-month period. A diagnosis of osteonecrosis occurring within 2 years of the usage of steroids, and no other cause of osteonecrosis besides the steroid use. Because there are many other causes of osteoporosis, including storage diseases, vascular causes, and others. Alcohol is also a very important cause of osteonecrosis. So the mechanism by which corticosteroids induce osteonecrosis or avascular necrosis, which we call, could be because of the apoptosis of the osteocytes. It could be an imbalance in the osteoblast and osteoclast, where there is increased osteoclastogenesis as compared to osteoblastogenesis, certain lipid abnormalities, coagulation abnormalities, because corticosteroids have been found to have an antifibrinolytic effect. It could be oxidative stress, or it could be the effects on the vasoactive substances, where studies have shown that glucocorticoids can actually decrease the nitric oxide by inhibiting the nitric oxide synthase. Alcohol also has an effect on osteonecrosis, and steroids, they may do so by altering the lipid effects, which could be fatty liver, which could be swelling and necrosis of the fat cells, lipid-filled osteocytes, dyslipidemia, adipogenesis of the marrow stromal cells, and fat emboli. So it passes the osteonecrosis or the avascular necrosis, passes through stages. I just want to emphasize that the first two stages are actually reversible, whereas in the later stages, they are irreversible. Just to give an example of some radiological findings. So this is a radiolucent crescent in the subchondral region, and this occurs, this is very typical of osteonecrosis and one of the earliest findings. And this is because of the collapse of the necrotic bone, resulting in a translucent area. But when the disease progresses, there might be sclerotic appearance like this. And this is because of microfracture with collapse of the bone, and also the calcification of the dendritic or the dead marrow, and also new bone formation. So these phases are all irreversible. So the treatment, again, could be divided into non-surgical and surgical. So non-surgical treatment includes pain relief, avoidance of weight bearing, electrical stimulation like shock wave, growth factors have been tried, and stem cell transplantation. Surgical treatment includes core decompression, bone grafting, osteotomy, and arthroplasty. Now, the effects of sex hormone and lipid disorders. We know that in menopause, there is associated, or in estrogen deficiency states, there is associated osteoporosis. Again, I'm not discussing that, but rather, anterior cruciate ligament tears occurs 2 to 8 times more in females athletes than in males. And this has been proposed to be because of the estrogen-induced knee laxity. And certain dyslipidemia, especially type 2 and 4, may occasionally present with arthritis, which respond to lipid-lowering therapy. Now coming to rickets, I shall just touch it because of want of time. So calcium and phosphate are 2 major minerals for the crystalline bone. Rickets is characterized by deficient mineralization of the growth plate with architectural disruption, whereas osteomalacia is characterized by defective mineralization of the bone matrix. So rickets occur when growth plates are open. So the major causes of rickets could be calciopenic rickets and phosphobenign rickets. Again, there are many causes for these, which we can discuss if we have time. So the normal growth plate, that is the endochondral calcification. So the upper end is taken as the epiphyseal end, and this is the metaphyseal end. So there is a resting zone of the cartilage, and then there is a proliferative zone, then there is a hypertrophic zone. Now the hypertrophic zone undergoes apoptosis in the presence of phosphate and other ions, and then there is calcification. So in rickets, what happens is that the hypertrophic zone does not undergo apoptosis, and also there is no mineralization, and therefore there is the formation of unmineralized deformed osteoid tissue accumulates. So again, there are lots of bony findings, but typically for the joints, there is widening of the wrist and bowing of the distal radius and the ulna, and the progressive lateral bowing of the femur and tibia, and also there could be kyphoscoliosis. So the earliest sign is the loss of demarcation between the metaphysis and the growth plate here. And also other features, again, this was a part of the quiz, the cupping, splaying, and fraying all seen here. There could be demineralization of the bone, and there could be delayed epiphyseal bone centers. Now coming to gout. So gout is monosodium urate crystal deposition disease, which is associated with extracellular fluid urate saturation, especially when the uric acid is more than 6.8 milligrams per deciliter. But please do remember, sometimes even during an attack of gout, the uric acid may not be so high. Also, please remember that most hyperuricemic individuals never experience an attack of gout. So the clinical spectrum could be recurrent flares of inflammatory arthritis, typically monoarticular and sometimes oligoarticular, which is self-limiting. Sometimes it may progress to chronic arthropathy, especially in the absence of the urate lowering drugs in the past. There could be accumulation of urate crystals in the form of tophaceous deposits, or there could be uric acid nephrolithiasis and acronic nephropathy. So this is the typical findings in gout, where we can see there is a swelling of the metatarsal phalangeal joint. We see that it looks inflamed, angry, red. So this is a typical symptom, which is very, very painful. Then we can see tophaceous deposits here. We can see the needle-like crystals, which is typical of gout. And this would be different from the crystals that we see in pseudo-gout. Again, this is a typical X-ray finding of gouty arthritis, where there is of gout, chronic gout, where there is a destruction of the metatarsophalangeal space. along with well demarcated margins with overhanging edges with the adjacent soft tissue density. Now, another one is the calcium pyrophosphate deposition disease. So the terminology is of the CPP deposition according to the European League Against Rheumatism. So they have the acute CPP crystal arthritis, which we used to know as a pseudo gout, where there is acute attacks of CPPD-induced synovitis, resembling very much the acute gout. They are recurrent, they're usually monoarticular and self-limited flares of inflammatory arteries that often resolve completely, unlike in inflammatory arthritis, like in rheumatoid arthritis, where they do not resolve completely. But most patients with a calcium pyrophosphate deposition do not experience such attacks. And then there could be cartilage calcifications also. This is important in our context because many endocrine and metabolic disorders are associated with calcium pyrophosphate deposition, which could include hemochromatosis, hyperparathyroidism, hyperphosphatemia, hypomagnesemia, Gitelman syndrome, and gout itself. So there are a spectrum of presentations. So somebody may be having the calcium pyrophosphate deposition, but be entirely asymptomatic. Or there could be acute attacks of crystal arthritis, just like in the urate gout, that is a urate arthropathy. Sometimes there is chronic CPP crystal inflammatory arthritis, which comes off and goes, very much seems like the rheumatoid arthritis. Sometimes it may be associated with osteoarthritis. In fact, the presence of these crystals may worsen the natural history of osteoarthritis. Then it's known as the pseudo-osteoarthritis. Sometimes it may be present in the setting of a neuropathy where there is a significant joint degeneration. Then it is known as a pseudo-neuroarthropathic joint. And then there could be spinal involvement. So the typical one I have already discussed, pain. Like for the gout, the typical joint that is affected is first metatarsophalangeal joints. But in the pseudo-gout or the acute CPP crystal arthritis, it is the knees that are most commonly affected. And sometimes there are acute flares after parathyroidectomy. As part of the hungry bone syndrome, when the calcium and phosphate are taken up by the bone, there is precipitation of the calcium pyrophosphate crystals. Or it could be part of, seem very much like a rheumatoid arthritis because it's chronic in nature, and therefore it is also known as pseudo-rheumatoid arthritis. But what needs to be differentiated is that the inflammatory flares may be asynchronous in the joints, unlike in rheumatoid arthritis. So when somebody has a flare of rheumatoid arthritis, usually the involvements are synchronous, but here the arthritis, the involvement may be asynchronous. But yes, it can affect multiple joints in a symmetrical or near symmetrical manner. Morning stiffness and all may be present, which may be confused with a rheumatoid arthritis. Pseudo-osteoarthritis, the presence of the crystals actually could have a, like I've said, worsen the natural history of osteoarthritis. It is sometimes seen in association with neuropathy, where severe joint degeneration and destructions may be seen. And when neurological disorders are present, CPP crystals amplify the joint destruction. There is also spinal involvement in the form of stiffness and bony ankylosis and crystal deposition in the ligamental phlebum or the posterior longitudinal ligament of the spine may be seen that can cause spinal cord compression. So the findings are based on the history and the typical crystals on the examination of the synovial fluid. And there are radiological features which could be normal, or there could be evidences of cartilaginous calcifications and degenerative changes. And in the USG, there could be, hyperechoic deposits, which may be amorphous in the fibrocartilage of the joints, in the bursa, and in the linear in the tendon fibers. So this is, again, this was a part of the quiz, faintly yellow positive birefringent rhomboidal intracellular. I think in the question it was extracellular. So intracellular crystal of calcium pyrophosphate dihydrate is seen in the synovial fluid of an acute CPP arthritis. And we see there is chondrocalcinosis of the wrist. This is a USG of the wrist where we see there are hyperechoic areas. So biochemical and hormonal evaluation we need to do in somebody presenting with CPP deposition disease is calcium, at least a calcium, phosphorus, magnesium, alkaline phosphatase, parathyroid hormone, iron, and transferrin, and then treat them according to the cause. Coming to hemochromatosis, hemochromatosis refers to iron overload. So hereditary hemochromatosis is an autosomal recessive disorder where there is a mutation in the hereditary hemochromatosis gene, leading to low levels of hepcidin and increased absorption of iron. So the absorption of iron takes place over the years, and the clinical manifestations takes place when the iron deposit in the body is equivalent to around 20 grams. There are other mutations that are also identified. And also there could be the clinical manifestation is heterogeneous in the sense that not all with the mutation develop the features of iron overload. So coming to the arthritis, it occurs in around 50 to 80%, typically is a late feature. Now the articular involvement is the second and third MP joint typically affected, but can also involve other joints, and there could also be the calcium pyrophosphate deposition. Along with the arthritis or the arthralgia, there could be hepatic abnormalities, skin pigmentations, arthritis, diabetes, mellitus, erectile dysfunction, or which is hypogonadism, which is mostly secondary hypogonadism, heart enlargement, and all conduction defects. So this is a typical arthritis, which occurs in the second and the third metacarpophalangeal joints, which is characteristics of hereditary hemochromatosis. So I have tried to include a lot of topics that are associated with arthropathy, endocrine conditions affecting particular endocrine glands, or metabolic conditions that are associated with arthropathy. I'm sure I have left out a lot of them also due to want of time. But to conclude, endocrine arthropathies are frequently encountered. They may be the presenting symptoms or sometimes a late manifestation of the disease. The arthropathies have significant impact on the morbidity and the quality of life. Early diagnosis and identification improves outcome in many of them, for example, in acromegali, for example, in rickets, and for example, even in gout, where it would prevent the early diagnosis and proper treatment, would prevent the recurrent attacks of gout, and also prevent the progression of the gout, or for that matter, the crystal deposition disease to a chronic arthropathy state. Thank you.